Welcome to a basic introduction to mechanical ventilation. This is chapter 6.1, Ventilating Asthmatics. In this chapter, we're going to cover the aspects of ventilating patients with severe asthma. This chapter will be broken into three parts in order to go into more detail on specific aspects of ventilating this patient population, as well as to more fully explain the underlying pathophysiology. First, we're going to talk about pulmonary hyperinflation. Asthma is associated with increased airway resistance, hyperinflation, and increased dead space. Patients with severe asthma usually breathe at pretty close to their total lung capacity. Unfortunately, mechanical ventilation usually makes this worse. Recall that hyperinflation occurs when high airway resistance delays the passive exhalation of air, usually occurring because the flow is at a much lower rate. Hyperinflation, however, is actually somewhat protective, as the stretched out lungs have a higher recoil pressure that permits higher airflow to permit more exhalation. As well, the airways are stretched open a little bit more, which helps reduce some of the resistance. However, the higher airway pressures cause increased intrathoracic pressure, and this can cause barotrauma and hypotension from poor venous return. As you can well imagine, mechanical ventilation will only make all of this much worse. This occurs both by inappropriate high tidal volumes and setting too fast of a respiratory rate. Now remember, just like spontaneous breathing, the exhalation on mechanical ventilation is passive and at a lower flow rate. Therefore, there needs to be sufficient time for exhalation, or the residual gas will be trapped and add to the tidal volume of the next delivered breath. Pulmonary hyperinflation needs to be closely monitored, as it can vary over time. Because of the high resistance and through the equation of motion, we cannot rely on the peak airway pressure as a measure of the degree of hyperinflation. Plateau pressures measure the average alveolar pressure, since most asthmatics have normal lung compliance. If a constant tidal volume is used, changes in the degree of hyperinflation can be inferred from changes in the plateau pressure. A plateau pressure of less than 30 centimeters of water is generally considered safe to avoid barotrauma. But similarly, the intrinsic PEEP needs to be measured by the end expiratory airway occlusion to provide a measure of the degree of hyperinflation. It is not uncommon for asthmatics to have an intrinsic PEEP of between 10 to 15 centimeters of water when they're at their worst. Changes in the intrinsic PEEP tracks the changes in the plateau pressures that occur with pulmonary hyperinflation, and either or both can be helpful in following hyperinflation.